topic, now you can sit down. This is a topic that we were supposed to cover yesterday, and because of interest of time, we were not able to do so. But it is one of the most important topics when you're designing your clinical trial. And that is, what is the outcome that you're going to use to judge whether that intervention works or does not work, okay? And there are many things, as one of the questions we had before was, should I have only one outcome? Most of the times we have multiple outcomes because every condition is reflected into different types of events, different types of metrics or measurements. And so I would be interested in having the intervention work for everything that is related to that. So when we are designing a trial, we will have to, as Professor J. Seelan showed you, calculate the necessary sample size for what? For testing efficacy on the primary outcome. When we are deciding the effect size, it's the effect size of what? Of that primary outcome. So it's primary outcome, after I have my hypothesis, whether it's superiority or non-inferiority, the outcome is the next important thing in that picot that I'm doing. An outcome is the essential one before I can design anything. Your homework tonight is going to be to come out with an outcome for your trial that you're designing. So that's why I did not want to postpone it. We had scheduled adaptive designs. We will try to get to that today. If not, we will get to it tomorrow. But relax, everything will be covered that's in the schedule. All right. So primary outcome, we'll talk about, it can be a clinical event. We'll talk about it being whether it's the occurrence of that clinical event or it's time to event. We're talking about survival analysis or whatever, that's time to event analysis. It'll hopefully become clearer when we talk about it. The primary outcome can be a measurement or an observation. Did this person reduce their weight by this amount? Did this person increase their CD4 count to such and such? Or I can be observing that this person now have had a stroke or not. So I can observe something, I can measure something. Those are the types of things that are going to be potential primary outcomes. But as I said, we always have multiple outcomes of interest. How do we handle this? And there's different ways that we handle it. We'll be discussing some of this. Nowadays, people are wanting to study everything that happens. And so we have things when you don't die of your heart attack, but we continue to follow you, you may have another heart attack. And oh, what, should I count the 2 heart attacks or just use 1 heart attack? So no, let's count as many as possible because then we have more data and more events to count. Oh no, but they're correlated within a person. How do I handle that? That becomes another issue. So we have this recurrent events issue. Okay, so let's start off. So the primary efficacy outcome is the most important metric. It's one that you choose as the one that you will determine the effectiveness of the treatment based on that. It's that key variable. And that's the one that is to answer your research question, but it's also to calculate your sample size. And so that's very important. You have to choose it. How do you choose it? Well, you should have it one that is clinically important, clinically relevant. You're not going to choose anything because this one gives me the smallest sample size, I'm going to choose it. If it's not clinically important, then it's not important to be chosen as the primary. It should directly address the main objective of the study. It should be well defined. It's not ambiguous. In fact, saying heart failure hospitalization, that sounds definitive, clear. No. Hospitalization for what condition of heart failure that do you want to have an ejection fraction less than such and such? Is it going to have this? Is it the timing of it, when it occurs? Is it what a referral to this? Hospitalization is also affected by access to care. And some people would need to be hospitalized, but don't get hospitalized because they don't have access. So then it becomes ambiguous what is happening here. What is the most unambiguous one? Death from any cause. Hopefully, people know if you are dead or alive. But even coronary heart disease death, how do we know? If they died suddenly in the street, do we know that they dropped down? Was it due to a heart attack? Was it due to something else? So you want to be unambiguously defined. It should be observable, measurable. It should be reliable, so they can do it accurately, and measured and reliably, consistently in everybody. Nowadays, there's a movement for it to be patient-centered, because the patient may not care that much that my atrial fibrillation is such and such. I only care about my ability to function. And so functionality may be something as a primary outcome. But then you say, oh, that's so unambiguously that, or it's too soft, or anxiety, depression, that's patient-centered, but it's hard to measure. So the selection of the primary outcome is not trivial, because it's going to impact everything. Your design of your study, your sample size, and what you're going to have as the judgment of that intervention. But it is a difficult one to make. And that's why I say that you have to have prior knowledge of what you're studying. If you don't have this prior knowledge, then you should not be doing a clinical trial, right? So you need to be comfortable in the choice of that primary outcome. Now, there are clinical criteria, there are practical criteria. As I said, it should be clinically meaningful or important, but to whom? To you as the clinician, to patients, to healthcare providers, to funders. I should have put there also to the government, because if I can show that I can reduce this, the government cares about this, then policy may change and practice may change. So if I show that this works, then maybe other clinicians will change their practice. Or if I show this is important to patients, then patients will change their behavior. So it becomes important to decide who am I trying to convince to change their behavior or their policy. It should be something that your intervention should affect. If it's not going to affect it, then why are you choosing that as your outcome? So in a reasonable time period, because if you're trying to say, oh, I want to see, all-cause mortality, and I'm studying 25 to 39-year-old people with this condition, I'm going to be dead before any of these people die. So then it's not going to be something that I will be able to observe. So I'm not going to choose that as my outcome. So it has to be one that I can observe it and it's modifiable by the intervention. And as I said before, that it will warrant change in clinical practice. Therefore, that it has an impact, okay? And those are the clinical criteria, but the practical criteria are the ones that I've already mentioned, some of those, that it is measurable with accuracy and precision, that it's unambiguously determined, and not too costly. If, for example, I have to look at lacunar strokes, and that's going to require that I do an MRI on everybody to see if they have it, and I have to do that every 3 months, I have to have $1 billion study. That's impossible to do. So I'm not going to do that. So I have to choose something that is not too costly. In an event-driven RCT, and we'll talk about event-driven on Thursday or Wednesday, tomorrow. If you have your RCT where it's not just the number of events, but the rate of events occurring, you want to have a high event rate so as to reduce the sample size, reduce study duration, increase power. That's why if you remember yesterday, I mentioned that CPPT trial, they studied highly risk men at high risk of having coronary heart disease. Why? Because they wanted to have more events and reduce the sample size a bit. That's why they didn't study women. That's why they didn't study younger men, for example. So you choose it with clinical criteria, you choose it with practical criteria. So I want to make a distinction that most people do not do. They say sometimes, oh, my study event is such and such, or my study endpoint is such and such, or my study outcome is such and such. And they use those three things as synonymous. They are not. Event and endpoint you can consider as synonymous, but outcome is a random variable. So now I'm talking as a statistician. Event and endpoints are clinical things that happen to you. So a heart attack happens to you, but the outcome is a random variable. And so I take an example, stroke. Stroke is a clinical event. You get this clinical problem of a stroke, but the outcome could be a binary random variable, which is the occurrence of a stroke, yes or no, within a specified time period of a year, 2 years, whatever. Or I can have it as a count variable, number of occurrences of stroke within a specified time period, or the incidence rate if you want it, instead of doing counts. Or I could have it as a survival random variable, which is time to the first occurrence of stroke. Or I can have it as recurrent events, timing of occurrences of stroke, like time to the first one, then time for the first one to the second one, time to the second one to the third one. Or I should have put there also, you could have total events. How many strokes did you have? That's sort of the count that you have there. And so you see that just saying, oh, my outcome is stroke, that's not adequate. And it's actually incorrect from a statistical standpoint. Your endpoint is stroke, your clinical event is stroke, but you have to tell me what is your outcome? What is your random variable that you're using that clinical event to determine, okay? Because when we do a binary one, we'll be comparing proportions between the intervention and control arm. When we're doing count, we are comparing incidence rate ratios. We haven't talked about that, but that's the outcome metric that you would use. If we're doing survival, you will be doing hazard rate ratios that Professor Jayasilan mentioned. If we're doing recurrent events, now we're doing the counts and doing the incidence rate ratios. So depending on which outcome variable you use is the type of metric that we will use and the way we will judge the efficacy of the intervention. So most of the time, we say that for a particular condition, yeah, you're forcing me to choose a primary outcome for sample size and for judging the efficacy, but there are multiple things that could be used that are reflective of the efficacy of the intervention for this condition. So for example, in cardiovascular disease, we could be looking at MI, we could be looking at stroke, heart failure, hospitalization, CVD death. We could be looking at biomarkers like NT-proBNP or troponin or the lipoproteins. We could be looking at functionality as mobility, ability to grip strength, for example, we look at. Or we could be looking at patient-centered outcomes related to coronary heart disease, quality of life, activities, able to function and do activities of daily living. But you are forced to choose one as the primary. You can still have the other ones, but you still are forced to choose one as the primary. So you have options. You can choose one as a primary because that's what is required. You can choose 2 or 3 more and call them, well, these are my multiple primaries. Or some people use the term co-primary, okay? And so you say multiple primaries. Well, how many multiple primaries are you allowed? 2, 3? Usually I have not seen more than 2, sometimes 3, but you cannot say I have 17 multiple primaries. Then nothing is primary. So you have to have some sense here, right? If you have multiple primaries, then you are doing multiple testing. And so you have to deal with multiple testing. And I'll give some examples of that. The other thing to do is to create a composite endpoint, a composite event. And there's traditional composites, and we'll talk about that. This occurs if any of the component occurs. There's something that was proposed by Professor Stuart Pocock in 2012. He called it the win ratio. And it is a summary of comparing who wins and who loses of one person from one arm with the other person with respect to any of the components in some hierarchical order. He proposed it. And nowadays, actually, he came to visit us 2 years ago. And he says, oh, no, I don't think it works very much. But he presented it. And all of the investigators in our group got very much interested in this. Oh, let's do win ratio for this and that. And I'll talk about the win ratio. There's other things also that are called overall clinical outcome. And this is something that is being proposed because it's trying to incorporate not only one good thing, but also looking at all the bad things too. So as I was talking about with anticoagulants, you may reduce the strokes, but you may increase bleeding. So how do I take good things and decrease in stroke, but increase in bleeding together? So then they create an overall clinical outcome kind of composite. So we'll talk about that as well. So how do we handle outcomes? So what are possible outcomes that we can have? We can have with a binary variable, we would be looking at the occurrence of the endpoint in a given time period. So we would calculate the proportion in one arm, the proportion in the other. But because this is a prospective study, we can calculate the ratio of proportions. And those are the risk ratio, or the more common term for it is relative risk. Okay. If it's the count variable, then it's the number of occurrences of the endpoint in a given time period. So it's that incidence rate in one arm and the incidence rate in the other arm. And so now we can calculate the ratio of them. So incidence rate ratio. Survival variable is the time to the first occurrence of the endpoint. And we'll talk more tomorrow about what hazard is, but you would calculate it's related to that incidence rate, but it is a more different theoretical way of looking at it. And we calculate the hazard rate in one arm, and we calculate the hazard rate in the other arm. And so then we can get the hazard rate ratio, which unfortunately we drop one of the R's and we just call it HR, but it should be HRR, just like incidence rate ratio. The win ratio is a continuous variable and it leads to a t-test. The overall clinical outcome rankings we'll talk about leads to a Wilcoxon rank sum test, for example. So handling multiple yes, question.
Composite outcome would be a binary variable, yes?
Yeah, so the traditional composite is an event. It's an endpoint.
Yes.
If any of these things inside here occurs, then it occurs, yes or no. I can treat it as a binary, but so it's another event. So I can treat it multiple ways. I can treat it as a binary. It occurred or did not occur in a given specific time. I can treat it also as a count, saying how many of these composites occurred in a given time period. I can treat it as time to the first occurrence of any
one of the,
or I can have the multiple. So I can do anything with it. Now, most of the time at our institute, they do time to the first occurrence of the composite. Why do they do that? Because it's simple. The time to event outcome is a one that many people understand. Everybody loves the log rank test. Everybody loves the Cox model. We'll talk about these on Thursday. And there's another additional benefit that many people don't realize. If I have to do the binary variable, did it occur or it did not occur in 2 years? I have to observe if it occurred or not. If the patient has lost the follow-up, then I don't know if it occurred or not. So then I have missing data. And we'll see that's a complication. But if I say time to the first occurrence of the endpoint, when the person has lost the follow-up, I've stopped that following that person on that date. And so the information is censored, and there's ways to handle the censoring. Oh, and I also don't lose any data. So that's the other thing. People love to do time to the first occurrence because they don't have missing outcome data. Even if the person stopped after 2 days, didn't come up anymore, at least we had 2 days of exposure and they didn't get that. Yes.
So, recurrent occurrences, if you want to see the time to recurrent occurrences, what parameter will you use?
That's the most complicated analysis here. There are not very good ways of handling this. There are many types of models that are trying to get to recurrent event analysis. There's an Anderson-Gill model, the Prentice Way, PWP method of different ones, and it's very complicated. So we will talk just briefly, I'll just mention it, but I think it's beyond the scope of this. Yeah, for all of these, at the end, you will report the p-value of this. Whatever your primary outcome is, that's your one you're going to use to test. And whenever you're testing, as Professor J.S. Salem said, you will end up with the p-value. And you would end up with the p-value for this, for this, for this, for this, for this. All of these tests have ways of calculating significance. That's why they exist. Oh, you can do confidence intervals for this. 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 And people don't know you can also do confidence intervals for this. You can do the same thing. They exist. All these tests exist. All this methodology has been worked out by statisticians. Okay. Well,
and then you have a number.
Yep.
Could
So
we
you-
also have
so you could have a composite that is a scored composite
a sc-
that you can either do it as a summation
Yeah.
of number of, there's 4 components. You
right?
can have 0, 1, 2, 3, 4, or you could have weighted scoring. So this one I'm going to give, if it occurs, I'll give it a 10. If this one occurs, I'll give it a 5. If this one occurs, I'll give it a 1. And this one, I'll give it a 1. And then you can get the score. You can do all sorts of things. Whenever you're creating an outcome, it's crucial that it has to be clinically relevant. And it also has to be one that your peers, your area of research, will accept and acknowledge this is a meaningful thing. But when you do scoring, I can guarantee you, if somebody else has not published it and validated it, and you said, I'm going to give it this, they'll say, why did you give it a 10?
Okay.
Why didn't you give it a 15? Or do you put a 5 score for this? Why didn't you give it a 7? Why didn't you give it a 2? They will criticize. Anytime you do scoring, you're opening yourself to criticism.
Right.
So you better validate and show that this has good psychometric properties, good interpretation properties, has content validity, has this validity, has that validity, before you start doing anything that is new and creative as an outcome variable.
Is there a restriction on the number of components that can go into a composite score?
Throw the garbage can in it if you want. But no, most times they are well accepted ones, and I'll give some examples of composites. But again, and the criteria for how many. Usually you don't have too many.
Yeah.
You will have what's reasonable, and again, you have to defend it. There are some standard ones that are used in different disciplines. And so people tend to stick to the standard so they don't get criticized.
Right.
If you start going away from the standard, you have the same thing as with the scoring. You have to justify it. You have to have shown that this has some predictive validity, that it has content validity, that it has, phase validity, that you have gotten a group of experts in that field and they agree this makes sense. Right? This will change our clinical practice if you show that it works for this.
Right. If I would 8 be a good number because I'm going to base it on life's essential 8. I mean the AHA's recommendations.
So that seems reasonable. I'm not an expert in that area, so I cannot tell you.
Yeah.
But you should talk to others that work
Experts,
in that area, and they think so. And you say, doctors X, Y, and Z, eminent people have said so, then maybe it'll fly.
Thank you.
So multiple outcomes. As I said, you have these options that you can do. This is such a big issue that the U.S. Food and Drug Administration, the FDA, came out with guidelines for industry. Okay, guidelines for industry mean exactly that. They're not guidelines for all trials. They're guidelines for regulatory trials, usually on drugs or devices that are going to come under their review. Now, most people beyond the United States always, as I said yesterday, follow guidance from the US FDA because they want their studies or their interventions that are being tested in India, in Japan, in Cameroon, in Argentina, to be sold in the United States so they can make money. So everybody follows the guidance of the FDA, whether they have to or not. And what does the FDA do? Well, they have this document is freely available. You can download it. And they are extremely detailed, as you would expect, on how to handle different issues. And I looked at there on how they suggest things. And one of those is that if you have multiple primary, okay, because you're not willing to have just one, you want to have multiple, then you have to protect what they call the family-wise error rate, usually 0.05. And so how do you go about doing that? There are so many different ways that pharma has come. We had one study sponsored by Bayer, and it had in the SAP charter, in the SAP statistical analysis plan, they had an addendum that was 9 pages on how to do multiple outcomes. And 9 pages of this. If this happens, then do this. If that happens, then do that. On and on and on. Typical things that are done is what's called hierarchical testing. Hierarchical testing is, let's say I have outcomes A, B, and C, right? Whatever they are. So I have A, B, and C, but I have an overall alpha of 0.05. Then I would hierarchically say which one is more important than the others. You decide. Oh, wait a second. Then I want to have C and then B and A. So then I will, in what's called gatekeeping, I will use this alpha for this and test whether this outcome, the intervention works for this outcome. And if it's not significant, then I stop. Don't do more. I don't test this outcome or this outcome. But if it is significant, then the gate is open and that alpha gets transferred to this next one. and then do the same thing. And if it's not significant, I stop. If it is significant, that gate is open and I go over here. And so if you have gazillion, you're going to stop at it. They had about 6 that they wanted. And so then you have all of this. Now, the other one is they do it with sometimes with what's called fallback. And fallback is I don't initially give all of it to this. I'll give this one, let's say 0.4, and keep 0.1 for this. Because if it's not significant, so if it's significant, that gate is open and that 0.4 comes here. And now I test this at 0.5. But if the gate is not open and I stop this one, I still can test this one at 0.01. So I keep some of it so that I can do it there. So I don't, put all my eggs in one basket. I keep a little bit on reserve. So I have a fallback that I'm not going to fall on over the, and I'll have a cushion at least a little bit. There's also, they'll do, this is what the Bayer people did. They had weighted alpha allocation. Oh, so I'm going to weight this one and I'll give 0.033 here. I'll give 0.011, and now I have what, 4.4, so 0.006 here. And then I'll weight it this way and I'll do all sorts of complicated. I'll go from this to that, if this is not this, and da 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 da. And they do all sorts of complications. Why? Because they want to have their cake and eat it too, basically is what it is. So yes, you can look at some of, they will not tell you this because it's proprietary pharma intellectual property, but they do this kind of stuff. Why? Because they want to show that my drug works for something. And I don't want to do it for just one primer, right? But that happens, it does. Now, and the FDA gives you guidance of how you will do this kind of stuff and very detailed if you want to follow. One that is very interesting, and you had to read it very carefully because as far as the FDA is concerned, co-primary is different from having 2 outcomes. If I have 2 primary outcomes, so let's say I have A and B, okay? I still have to share the alpha some way. I can do it gatekeeping or not, but if I have 2 outcomes, A and B, I can call them, I have multiple outcomes, or I can say I have 2 co-primary. That to me is synonymous. To the FDA, it's not. If I have multiple outcomes and I'm saying I'm testing this at 0.04 and 0.01, and I'm not doing gatekeeping, I'm just doing sharing. So I give some here and I give some here, but I'm not doing a gatekeeping of passing that. I'm just sharing. I can show maybe this turns out to be significant and this turns out to be not significant. I can report significance and I can report not significance here. If I call it multiple outcomes, the FDA is okay with that. But if I do the same thing and I call them co-primary, then even though this is significant, since this is not significant, they would say you cannot say that the intervention is effective. You need to have significance in both for you to say that the intervention is effective. And so what we normal people would say is synonymous, according to the regulatory agency, is not synonymous. So we have to be very careful when we are reviewing protocols. I'll tell the physicians, no, don't call it co-primary because you'll get in trouble with the FDA. Just call it, we have 2 primary outcomes. So that's just stupidity, but stupidity among bureaucrats is very important. No, it's up to you. If you're not submitting to the FDA, you can call them anything you want to. If you're not submitting to the FDA, you can call them anything you want to. Only if you are submitting the US FDA is that you have to worry about what you call it. It's not across the board, nobody cares. I call them 2 primary, that's it. And if it's a study that's a non-regulatory study, I'm doing a study of some behavioral intervention, I'm doing a home visitation or screening intervention, I can call them co-primary if I want to. It doesn't matter because the FDA is not going to be involved in it. Yeah. All right. So composite outcomes are very common done. And it's basically an amalgamation or lumping together, putting together several clinical events or components. They can be metrics that I used or I dichotomize them, and we do it into a single outcome. What matters is that it occurs, that event, the composite occurs if any of the component occurs. Okay, so there is no hierarchy. If you put together heart attack with angina and with nausea, because you decide to do that, maybe you have a lot of nausea, but you don't have any heart attacks. It doesn't make sense to do something like that. So care must be taken that everything you put into a composite is of similar clinical relevance, similar importance to patients or clinicians or to politicians, and similar rate of occurrence. So I'll give you an example would be, well, here's standard examples in cardiovascular, in rheumatoid arthritis, and in pulmonary hypertension. What are the composites that they typically use in these 3? I haphazardly chose this, not randomly, because I work in cardiovascular. I knew about MACE, and I looked up what things are used in other clinical disciplines, and they put these things. So, for example, they use indices in rheumatoid arthritis, flare responder indices, and so they come up with a composite that is based on some indices. I don't know if it's weighted or not. In pulmonary hypertension, they do worsening of symptoms, initiation of prostanoid therapy, I don't know what that is, lung transplantation, or atrial septostomy. I'm more familiar with MACE. MACE is major adverse cardiovascular event, and so that's heart attack, stroke, revascularization, and cardiovascular death. Some people don't put revascularization. Some people add heart failure hospitalization. So, we need to read when somebody puts MACE, since nobody is that careful to have a definition that is well understood. They assume that everybody's using what they're doing. They just put MACE. But journal editors will force you to say, what did you put in it? Because people do whatever they want to. And so be careful on it. Why do people put another event in? Because they will have more events occurring. And as Professor Jayasilan said, that the sample size calculation for time to event analysis is driven by how many events you get. So the more events I get, the fewer the sample size I'm going to need. So let's put in everything into this composite because I will have then smaller sample size. But the question is that new composite that you invented meaningful? You don't want to put in things that are not as important, that occur more frequently. Like if you put in MACE, if you put in atrial fibrillation and you put angina, they're not as equal importance as death or stroke or MI, but they occur more often. And so you'll get more events, but now when you're comparing the 2 arms, you may get inappropriate comparison, right? You had a question?
Can you combine clinical and a lab measure?
Yeah, you can do it. Again, basically the same answer to her question. If you are creating a new composite that's not a well-established composite that others have already done, then you'd better be prepared to defend it. And you have to defend it. You have to be, you will not necessarily get it accepted. First, by the funding agency on which you're submitting the proposal. Second, by your IRB. Third, by the clinicians that are working on your trial. And fourth, by the journal editors. And then fifth, maybe by the regulatory agencies. Be very careful. It's very attractive to let's make more things in here because I will get more events, right? Okay. Question. All right. This was an interesting one that was proposed about maybe 12 years ago. And that is, and it's a very nice, conceptually intuitive one. And so Stuart Pocock published this in the European Heart Journal in 2012. So he's a statistician, well-known statistician that works in cardiology. And he was saying what we should do is, let's say we have multiple people assigned to intervention or control. And so I have this person 001, 002, 003, up to 020 here. And I have 021, 022, up to 040 here. So I have 20 people here and 20 people here. And so what he's proposed to do was, I will, first of all, take the outcomes of interest. And so I have outcome A, B, C, and D, and I will rank them into their importance. Who determines importance? The physician, the patient, who? Somebody. It should not be arbitrary. So let's say A is better, A is the most important, B, C, and D. Now I will compare each person here to each person there. So this one is compared to this, 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 this. So I have 20 by 20. I have 4,000 comparisons. And I will compare them on A first. And if A occurs in this one, but not in this one, so now I'm comparing the one person in intervention, person number I, to control person number J. And if A occurs in I, but not in J, then which one wins? This one. Because he didn't get it, this one got it. And if it doesn't occur in either one, it's a tie. If it occurs in both, it's a tie. That's if it's a binary variable. But if it's a time to event outcome, then I have to see if it occurs, and if it occurs in both, in who it occurred earlier. That's the one that loses if it's a bad outcome. So see that it's not just the event, it's has to be the outcome that you're comparing. And that's why I make a distinction. The event is survival or is it occurrence? And so you have to do that. Now, if you will do it on A, then if you've resolved it on A, those comparisons, we take it out. So suppose out of this 4,000, maybe 322 are resolved. One wins or the other one wins. So now I'm left with 3,678. Now, these were the ties that occurred with A. Now I proceed with B and see how many are tied or are resolved with B. And I do the same thing. And say, let's say 415 are resolved. So I'm left with 3, 6, 2, 3. And now I proceed to C. And I do that again, check on C. And let's say 15 are resolved. only, because C doesn't occur very often, or it occurs when others already have occurred. So therefore, those have been resolved, so it's gone in the hierarchy. So now I have what, 8, 4, 2, and 3. Then I come to D, and I do it on D. Now, A, B, C, and D can be anything that I think is important. So let's say this is heart attack. And that this is a stroke. This is death. Why didn't I put death higher? Because somebody decided that it was more important to prevent this than death. Usually you would put death first, right? But somebody, let's say somebody decided. And then what if I put is satisfaction with my current health condition? Well, you can say poor satisfaction or high satisfaction. You can say poor satisfaction. Okay. But this is a continuous variable. These are binary variables, or one of this could be time to death. So this could be a survival outcome. This can be binary, and this is a continuous. If it's continuous, these 3,248 will be resolved on a continuous one. There won't be any ties, because we will have continuous variables will not be tied by definition, by theory, unless I measure it in a poor way. And so the answer will be driven by this. And you will be judging this effectiveness of intervention based on satisfaction, not on these things. If they don't occur very frequently, if there's a lot of ties, the continuous one will do it. And so he calculates the wins of A relative to the losses of A, and that's the win ratio. Okay? But the main problem with it is the ties, is deciding the hierarchy, deciding what is more important, and so forth. I've seen it used. He himself says, I don't like it anymore. I don't use it. He doesn't use it. But people think it gives you more power. It actually, we had one of the investigators who got so excited about it, he wanted to change, I think Kumar said, he wanted to change the primary outcome of his ongoing trial, do a protocol change, and do it with the win ratio, because he suspected that he was not going to get a big effect size with the current primary. And he said, oh, I will get more power with the win ratio. I want the win ratio. I want the win ratio. So then I said, I don't know the real, I was blinded, so I did not know. But I said, I will do some simulations to see if you get more power or not. And we did simulations, and now he convinced that, oh no, I don't get more power. So he stopped insisting on this, because it sounds very attractive. I can put all sorts of things, and I will now have things that are clinically important, patient-centered. I can look at hierarchy, and I can put a composite that is meaningful, etc. And people find it very intuitive to do. So this is one that I've seen. There's, so as I said, the win ratio depends on which components you put, the order in which you put it in, and which components are more likely to break ties than others, and censoring. And it's very key to have this, and you get this ambiguity, unfortunately, with it. And the thing is that, the win ratio for one study will be different for a win ratio in another study on the same disease, because it's not a standard one. Anybody can choose whatever they want to put as outcomes into it. There's another one that has become more recently proposed, and I just learned about this when I attended the Society for Clinical Trials meetings a month ago in Vancouver, and it's called the DOOR, D-O-O-R. It's not gatekeeping or door opening. It's an overall clinical outcome, and it's called the desirability of outcome ranking. And what it is that each patient's experience is characterized according to an overall clinical outcome. So now we are taking the patient's perspective included as well. It's carefully constructed. It's an ordinal categorical variable. So it's not a continuous variable. It's not binary. It's ordinal. So there is an order to the categories. And it's based on important clinical metrics of harm, benefits, quality of life. So what happens is that a patient are ranked as to, I take all of the different things. I take, let's say I still have these 4 things that are important that I'm going to consider as important outcomes. And now I will basically do like almost like a scoring like you were proposing. And so I will calculate the score of and compare the score of this patient with that patient. And so I'll get all these scores here for all 40, and I will then do basically a Mann-Whitney test, which is to compare the ranking, overall ranking of this with that and compare which is positioned where. That's why, since the Mann-Whitney test, I assume all of you have seen the Mann-Whitney test, is essentially exactly the same as the Wilcoxon rank sum test. And so that's what he's doing. They use the Wilcoxon rank sum test, but it's exactly the same thing as the Mann-Whitney test. And so they will compare the rankings here to the rankings here of that overall outcome or overall clinical outcome, which is a score. And if they're tied on the outcomes, then they will look at the time to the outcome or duration of exposure. They do this a lot in antibiotic use studies, and that's where I've seen it only. But this was interesting. I had never heard about this before, but this is something that is a potential one. Maybe the author, Scott Evans, who proposed it in 2016, will do same as Pocock, and 5 years, 10 years later will say, oh no, I don't like it anymore. But currently he likes it, currently he's promoting it, and it is intuitive and makes sense. Now, the final topic on outcomes was this recurrent event things. So I don't have a slide on it because it was going to be too technical to talk about. But what happens is you have that in all studies, you're following people prospectively. You may be interested in multiple different outcomes. You now can either have a choice of 1, a choice of 2 or 3. You create a new composite, or you can study all the timings of occurrences of all of these things. So you may have, you follow people and they enter your study, and you'll have, what happens is, let's say you have, I'm going to have 4 people. So I have patient 001, 002, 003, 004, and they are, this one enters the study here and is followed. This one enters the study here, followed here, goes up to here, and this one enters here and is followed here. And we will see tomorrow, we sort of move everybody to the same origin. But what can happen is, suppose I'm interested in outcomes of MACE. So I have heart attack, I'll have stroke, and I'll have CVD death, and I'll not, well, let's put in hospitalization for heart failure. Hospitalization. So what happens with somebody? This person may come in and will have an MI here. And if they don't die, what happens? They get treated. They get treated. They are hopefully now they have sort of put stents in, they've done this, they've done that, and this person, or maybe they've had PCI and they have been revascularated. And so now their risk is lower for subsequent things. Or maybe they're weak enough that they still are at high risk. And then they may get a stroke here. Then they may get heart failure, hospitalization, and then they die. Okay. This person here gets an MI, gets another MI, doesn't die. This person is hospitalized for heart failure and he got a stroke and got hospitalized and is doing okay. This person did not get anything. Okay. They were short time. Now, if we're doing composites, traditional composite, then it occurs if any one of them occurs. So we had, let's say these people were intervention, these people were in control. So we have two people. Intervention is worse because they're getting lots of stuff. Here, these controls are not. But look at this, that if I do traditional composite, there's these two people got it. Here, one out of two got it. Here, 2 out of 2. Okay, so that's shows that intervention is worse, which is what I would expect. But if I do in time to event, then we'll change this here. These here, no, let's let's leave it where it was. Let's not change the data. Time to the first occurrence is long here. It's longer here or similar here, but it's long here. And here they didn't get it. And it may show that intervention is actually not so bad compared to the other one because it's the time is a little bit delayed to that. For the traditional composite as a time to event. But now people are saying, I'm ignoring all of this information here. Why should I ignore that? Why don't I count them? So now we have this total event count. That's one way of doing it. And so we now look at the total events that you're having here and the total events that you're having here, and we'll show that this is worse than this. I should have called this the control arm. This is the intervention arm. We have less of the bad things. But that's one way of doing it, is total event analysis. The other one is, and that is a simple count of things, right? And so that's easier to do. But what many people are interested in is, what is the timing to this event? And then conditional that they've had one event, what is the timing to the next event? And what is the timing to the next event? And what is the timing to the next event? And timings here and timings here. So now I want to model multiple timings per person, knowing that the timings within a person are correlated, knowing that they also are dependent on what occurred. So the timing to the stroke is dependent on having had an MI here and the severity of the MI and on the treatment that we had. And so it depends on what we call time varying covariates. So these are confounders that we have to model. And we can look at the timing, and there's different ways, there are different models that have been proposed to do that. And as I said, the common one is the Anderson-Gill, there's the PWP model, and none of these are perfect. All of them have problems. People are working on understanding how to interpret the results of this. A more recent way of thinking about this that is being proposed is called the multi-state model. And the multi-state model is, you have a person is healthy, is little bit sick, a lot of bit sick, and dead. And so a person starts the study healthy, and at some point after 1 or 2 events, you say they're a little bit sick. After 3 or 4 events, you say they're a lot a bit sick. When they're dead, they're dead. And so these multi-state, we call them multi-state transition models are saying, how do people that start off healthy, little sick, lot sick, or dead, well, you don't start off dead, but you can end up stay healthy or move to little sick, lot sick, or dead. If you start off healthy at a given time point, after the study goes on, where are you? So this is a time specific transition model. And at given time, where have I been? So if I started healthy, what's the probability that I'm still healthy? Maybe it's still 80%, but a little bit sick is 17%. And then there's 2% that'll go here and 1% that died. And somebody that started a little bit sick, they only 5% became healthy after treatment. There was about 60% that stayed a little sick, but about 30% that came here and 5% that died. And if I was a lot sick, nobody went to healthy. Maybe about 8% went here. Here, about 50% went here, and 42% died. And so I can now calculate the probability of transitioning from one to the other. These models are time sensitive, so they will say they're all Bayesian models. So these are now Bayesian models of estimating probability, given that I know the prior probability of being in one of these groups, where they transition to, and we can calculate the transition probabilities, but we can also calculate your probability of how much time do you stay in your current state, because that's important. If I've gotten sick, but I can stay sick for a longer period of time and not get too very sick, that's good. I want to prevent me from going to the worst scenario. So these transition probabilities are estimated with usually standard logistic regression for ordinal categories, but it's the Bayesian way of thinking about I know something before, and then I observe the data and see where people are now, and I recalculate those probabilities. This is a recent thing. Professor Frank Harrell has written some papers on it. I can share them on it. And we are now trying to use this because what? Investigators at our institute were very much attracted in saying, I want to use recurrent events. And I said, why? Oh, because I get more events, I have more power. They only care about power. And I said, come on, don't you care about interpreting your results? And so now we have something that is actually more interpretable. These transition probabilities and the factors that lead to that probability being higher or lower are what we want to know. So this is now modeling the data in a clinical trial. It's not answering the research question. The research question is usually, does this intervention work or not? And once you get that answer, that's the primary analysis of your primary outcome, then you want to understand more. And those are secondary analyses. Tomorrow, we will talk about the primary analysis of the primary outcome in the clinical trial. We'll talk about secondary analysis of the primary outcome in the clinical trial, but we'll talk about secondary, supplementary, subsequent analyses of all of the outcomes in a clinical trial. The safety outcome, the secondary outcomes, the subgroups, the this, the that, and how we do those models. And this is one of those models that we are contemplating to use right now. But we haven't done it yet. So I don't have experience fitting these models. I'm just reading about it and learning about it at this moment. But I think that's the last slide I had. Oh, no, I guess I did this one already. Is it repeating? Did I go back? Oh, I went back to the first one. Okay. Somehow, oh, I must have pressed this without knowing. Okay, so that was the analysis of the primary outcome. There are other things that come up. Secondary outcomes. Okay. So you've chosen your primary, and you maybe made a composite of that. And you've taken 3 or 4 things and made it into a primary. But somebody said that, yes, we have a composite, but we also want to look at the individual components of that composite. That's a secondary analysis of those components. But I also have secondary outcomes that are not part of the primary one. And I have tertiary outcomes. So first of all, we have to realize that now we are in quicksand of terminology. So what I call secondary, somebody else will call tertiary. What I call exploratory, somebody else will call sensitivity. What I call surrogate, somebody else will call whatever. Terminology is a nightmare here. There is no standard, there is no terminology police that comes and hits you on the head. Oh, you call this tertiary, should be a secondary. People call anything whatever they want. So when you're reading it, beware that there is no standard of what people call anything beyond the primary. The primary is the only one that there is a police to tell you you have to have one primary. Okay? So secondary outcomes, why do we have them? Because we think they are important from a clinical standpoint. And what we are looking and focusing on is the result for the primary, do I see it consistently in the secondary? So I'm looking at consistency. I'm not looking at significance. I will say that again. Secondary ones, you are not testing for significance. In order to test for significance, you will have to have stated them as a hypothesis. You should also power for them. Most people don't power for secondary. If, like you wanted to power for everything, then power for everything. But you also then have to have multiple testing and correct for multiple testing. And these are not independent tests. All of these outcomes are correlated with each other. So a simple Bonferroni does not work. So you have to do a little bit more complex things if you want to test these things. The recommendation is that secondary outcomes should not be tested for significance. You can still estimate the effect for those. You can still look at the magnitude and direction of that effect. You can still provide the confidence intervals, but you should avoid the word significance or the word significance or lack of significance, because you have not specifically a priori powered on specified as hypothesis. So as I said, there are no p-values. The tertiary ones sometimes are confused. Some people only have secondary. Some people make that distinction. And like I said again, who knows how they decide what is secondary, what is tertiary. There is no guidelines on that. They're called the exploratory outcomes. And best practice for this is just to present the effect estimates, make no inference, and only generate hypothesis. Oh, this may be something that is going on. And then you can do it that way. The problem is that most people don't follow this. Most people put p-values. Most people throw significance around all over the place. They clutter their paper with p-values. Why? Because they think the journal editors want them. And yes, maybe journal editors do want them, maybe reviewers do want them, but you can fight back and you can get them not to want them. Then you have this recurrent event analysis. I don't have a slide for it, but I already talked about it. I have, well, we can stop now for questions, comments.